I'm Keith Fox, and here we are at the European Society of Cardiology in London, and we've had a session today on preventive interventional cardiology, if we understand what that is. And I'm delighted to be joined by Christian Spaulding from Paris and for Stefan James from Uppsala, two real experts in the field. And we're going to be talking about the issue of plaques, and plaques that may not be the culprit lesions. So Christian, one of the issues from the session today is lesions that were not the culprit lesion in MI, but they still stenosed. What should we do about them?
Well, thank you, Keith. That's a very, very important question. And there have been 3 studies that have been published in the last 2 years, the PRAMI study, the culprit study, and the Dynamic 3 PRIMI Multi study that have clearly shown that you can reduce adverse events after a STEMI if you treat the significant...
But Christian, these are all small studies.
Yes,
and
that's true.
First one was an implausibly large treatment effect.
Yeah, true, but the first one actually was stopped before the inclusion of all the patients because it showed a significant reduction not only of its primary endpoint, but it also showed a reduction of death and non-fatal MI, which is also a very, very important endpoint. So despite the fact that these studies were small, they did all 3 reach their endpoint, and one of them actually showed a reduction in death and non-fatal MI. So despite the fact that the trial designs were different in these 3 trials, the message is relatively clear. After you've treated the culprit lesion, you should treat the significant non-culprit lesions. Whether you treat them during the index procedure or after is a matter of choice that is based on the fact that is the lesion easy to treat? Does the patient have comorbidities? Are you going to have to talk with the surgeon because there could be an indication for surgery? Have you used a lot of contrast medium? But basically, to keep things simple, approximately 50% of the lesions will be treated during the emergency procedure and 50% of the lesions will be treated after, eventually guided by FFR to assess the severity of the lesion. So the message is clear: treat the significant non-culprit lesions either during the index procedure or during the hospital stay at 45-8 hours.
So these are the significant non-culprit lesions.
That's
and
right.
this is a complete reversal because the previous guideline said that this was class 3, don't do it. So this is coming all the way around to saying significant lesions, 3 studies now, and there is pretty good evidence that we should be doing something about it. And as you've given guidance as well in your hospital, if there's 3-vessel disease or a question of appropriateness of surgery, then diabetics, then the heart team needs to be involved.
Exactly, which means that in doubt, do not touch, and staff the patient the next day with the heart team, with the surgeon, to see if there's eventually an indication for CABG.
So Stefan, I have the tough question for you. Here we've heard about the non-culprit lesions which are hemodynamically significant, but what about the non-culprit lesions that are not hemodynamically significant? The vulnerable plaques among them. What do we do about these and how do we detect them?
So this is a very interesting and a more complex issue to deal with. You know, that for every significant lesion to be seen on an angiogram, there are plenty of stenoses that are marginal with a lot of plaques, and some of them are more prone to rupture or to develop acute events, thrombotic events. And so there are many imaging methodologies now out there to detect these, to see them with IVUS, with OCT, and also with near-infrared light to detect actually cholesterol pools within them. And there are also non-invasive methods to see them. The question is, should we just leave them alone with medical therapy, or should we go ahead and stent them? And as of today, there's no evidence really to stent these lesions. So clinically, no, you should leave them alone with optimal medical therapy. But there are interesting studies going on really to address, are there ways to identify these very accurately and go ahead and do something with them to stabilize them, to prevent future thrombotic events?
So if you just had one technique, Stefan, to say, look, I want to show up a vulnerable plaque, what would it be?
I think although there are challenges with all methodologies, I think the most mature one is still IVUS, because that's widespread. There's good evidence that there's links between the IVUS findings and poor outcome. But there are also other methodologies that are developing very strongly.
Yeah, but you're both reinforcing the importance of managing the underlying risk factors and all the lifestyle factors to modify this balance. So really, I guess what we've been talking about is, first of all, treating the non-culprit significant lesions, because there are 3 studies that are aligned in showing evidence of benefit, but being aware of the ones who may need to be referred for surgery. Stefan talking about the issue of vulnerable plaques among the remainder and novel techniques to identify these vulnerable plaques, and maybe in the future some smart techniques to treat them. But at the moment, hold back optimal medical therapy, and that sounds like a pretty good consensus.
Yes.
So from Stefan James, from Kristen Spaulding, and from myself, Keith Fox, thank you very much.